Hello there, this is Chapter 40, Patients with Special Challenges. Now, the first challenge for us are the communication issues. I know you probably already aware there are people that have hearing impairments and vision impairments. So when you arrive on scene, you don't automatically assume just because this is an elderly person that they might have hearing loss. If, as you're doing your assessment, you're seeing SIZIP, you see hearing aids in their ears or you see hearing aids on their nightstand somewhere next to them, that's great. Just make sure that you have the patient themselves or maybe a caregiver put the hearing aids in their ears and turn them on. That helps a lot. The patient might not yet have hearing aids, so you could ask them, raise your voice slightly. Don't shout at them, but try to discover maybe one ear hears better than the other ear, possibly. If the person can't hear at all, many can lip read, so they can, if you make sure you speak clearly, they can understand what you're saying by reading your lips. Or worst case scenario, you can write a note and hold it up, and they can communicate that way as well. So when it comes to vision impairment, again, it depends upon the degree of vision loss. If someone is legally blind, they can lose the majority of their vision due to macular degeneration or cataracts or other types of disease processes or even trauma. A lot of these people have service animals, and if they do have a service animal that helps them deal with their vision loss, they're more than welcome to come in the ambulance with the patient to the hospital. It's strongly recommended, as long as just no other issues that your department or agency might have with that, but shouldn't be a problem. Obviously, this person is unable to see. You might need to assist them, walk them to the gurney, holding their arm, directing them possibly. They may or may not resent this. So if they're in their own home and they're very familiar with their environment because they walk around there a lot, so they have landmarks, they might want to do it by themselves, and that's fine. Just stand close just to make sure. Now, obviously, if they have chest pain or they're dizzy or they've fallen and have neck and back problems, and we're not going to walk these people to the gurney. We're going to lift them up and carry them and place them on the gurney that way. Just explain to them that because of their medical or trauma condition, it's unwise for them to walk. Otherwise, if they're able to walk and they're in their own environment, that's no problem as long as you just stay close. Now, another big issue that's probably not in this portion of the book, but a big issue that I run into are language barriers. And these are communication challenges for us. So you arrive on scene and you have a person who speaks Farsi or Russian or some language that we aren't generally familiar with. There's a couple of resources for this. If you're talking about an extended family, so if you have second or third generation family members there, they more than likely are bilingual. Usually the younger family members, the teenagers and the 20 and 30-year-old people are usually bilingual, and they're able to interpret for you pretty well. And that seems to be across the board. If there's no one there at all other than the patient, and the patient only speaks their native language, you might involve the police or sheriffs. So a lot of times the police officers and the sheriffs, and they work in a particular area that has a certain ethnic population, they become familiar somewhat with the language. I know we have a very strong Russian population down off of like 54th and University, that whole area right there's a lot of elderly Russian people. And a lot of the police officers have some basic Russian that they can translate for you. So keep that in mind. Possibly you can also get on the phone and you can call the hospital, and the hospital can arrange for some type of phone language conversation going on. It's kind of complicated. I've never used it before myself personally. I try to limit it to the people around us, possibly. Sometimes even the firefighters or maybe your partner might have a smattering of the language. Find some way. Comes down to it, though, if there's no one who can interpret, we're all human basically, and our hand gestures are fairly similar. Our facial expressions are fairly similar. You can kind of direct this person and make them understand, or hopefully they can make you understand in a simple way what's going on. And please, 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 when you call the hospital to give you a radio report as you're going to the hospital, let them know that this person speaks a language, and so they'll have an interpreter there at scene, or at the hospital, should I say. So when they get there, it will make things a little easier. Paralysis. So paraplegic patient has lower extremities. Usually it's below the waist. So this is a person in the wheelchair. They can move their arms, they can move their head, they can feed themselves, they're talking, but they're paralyzed from the waist down from some type of traumatic injury or some kind of medical condition that caused damage to their spinal cord or column. Quadriplegics, that's all four extremities now. This is a person who has a very high lesion or injury to their spinal column or cord. So they've broken their neck at C3, C4, C2, way high up there, and they possibly affected their phrenic nerves. So they need to be on a ventilator. You can see this picture right here. This gentleman has a ventilator through a trach appliance in his neck right there, and he's completely paralyzed from the neck down. These people generally cannot breathe on their own because they lost their drive to breathe. They're on medications that keep their blood pressure up. Unfortunately, with the quadriplegics especially, they have a tendency to develop all kinds of infections, bacterial infections, and they become septic. They get pneumonia. And this is why we get called out for these people. They get some kind of bad infection or airway compromise due to their ventilator or their tracheal appliance getting blocked up or something like that. The assessment considerations really isn't that much different. Now remember, this person probably has no sensation or no normal sensation distal to their injury, so they're probably not going to be able to feel you touch them. Their limbs are going to be slack. There's no muscle tone whatsoever. Your blood pressures might not be that accurate because of this, because of their circulation to their limbs. But do the best you can. Whatever it is. You will be able to get a blood pressure on them as well as a pulse. Probably, again, not all that accurate, but it'll be there. And these people, because they're wheelchair bound or bedridden, and they can't get up and go to the bathroom, they're probably going to have a urinary catheter, a Foley catheter. So make sure that doesn't get caught on something. Remember, that goes up into your bladder and they urinate into a bag. So that all comes with them to the hospital. Lifting them out of their bed or wheelchair onto your gurney, make sure that catheter comes with them. You don't want to pull it out. That would be really, really terrible. Now, again, with transport considerations, remember these people they're paralyzed from let's say the shoulders or the neck down. They have no normal sensation to pain or discomfort. So when you go to put them on the gurney, you need to pad them really, really well. You should not have any kind of plastic or metal parts touching their skin, their bare skin. You should not have any of the gurney straps touching their bare skin, because they'll abrade their skin. They can cut and tear their skin, and because they have no sensation, they will not be aware that this is happening, and you don't want to cause harm to these patients. Now, like I mentioned before, these people that are quadriplegics, a lot of times they will have tracheostomy tubes or trach tubes. They might have a mature stoma as well. Really, there's a number of reasons why people get trach tubes. It's not just because they're quadriplegics. Someone who has a crushed larynx in an accident, the doctor might do an emergency tracheostomy. A child with epiglottitis, that they can't control the child's airway, the doctor might do an emergency tracheostomy tube, like you see here in this picture. In most cases, if a person has a trach tube in place, like you see here, they're going to have it for a while until they get better, or like with the quadriplegics, they have it for the rest of their life. The number one complication with this is going to be it gets blocked. with mucus and secretions from the airway. This is the number one reason why we get called out for this. Normally, if they have a caregiver, they have a suction catheter unit there. They probably tried to suction this already, but the junk in there gets just so sticky and so thick and so tenacious, it's hard to get out. Now, a lot of these, this one doesn't show it here in the picture, but a lot of the adult size tracheostomy tubes, they have an inner cannula. So you can actually twist off the top cap. You can slide out this inner cannula, and they'll have another sterile one somewhere in a package. You'll be able to slide that new one in, and it might solve their problem. So if the caregiver hasn't thought of that yet, or there's no one there to do it other than you, you're more than welcome to do that. But again, these things get pretty clogged up with gunk. And of course, other things can happen. They get infection around the site and things like that, redness and streaking and things like that. But the number one reason why we get called out for these people with trach tubes is usually because they're partially or completely blocked by some type of gunk. And again, these people who are on trach tubes, not everyone with a trach tube is on a ventilator or needs to be on a ventilator. But if they do, then they probably have one at home. It's a little small, maybe the size of, like the size of a large stereo or something. And it just basically pumps air in and out. It's actually, it provides ventilation in and allows the patient to exhale. So it has both phases, essentially, inspiratory, expiratory phases. And it's set, it has all these dials and knobs on it. Usually there's someone at scene, a caregiver or a family member who knows how to run this thing. So if you're going to go to the hospital, two things you have to remember. If you're going to go to the hospital with a patient on a ventilator, one, bring the person who knows how to use it with you. Bring any spare batteries that they might have, because these ventilators work on the normal household current, but they also have battery backups as well, for obvious reasons. And get your BVM out and have it at your side or have it near you, because if these ventilators do fail, and they do fail quite often, you'll have to take off the tubing and put the BVM onto their trach appliance and ventilate them manually. And again, this is just once every 6 seconds for an adult, just normal rescue breathing. If the patient can any way communicate with you, they can blink their eyes or make a face or something like that. Try that once every 6 seconds ventilation. Ask them, do they feel comfortable at that rate and the depth of ventilation? And if they can somehow communicate and say in their own way yes or no, you can decrease the amount of ventilations or increase it depending on their needs. So you really have to concentrate pretty hard on this while you're doing that. We go on a lot of calls with people who have home oxygen. This is a person who has maybe lung cancer, or they're emphysemics or chronic bronchitis patients, or they're recovering from some kind of respiratory problem. There's two most common ways oxygen is delivered to these people. One is the big green tank right there. That's the oxygen cylinder. You're going to find that probably near the front door for obvious reasons. And then there's going to be this really long oxygen tubing that goes from that tank to wherever the patient might be. So guess what? If you follow this long tubing, you're probably going to wind up finding the patient. It's kind of like fishing, so to speak. I've seen these tubes, these lengths of tubing to be 30 and 40 and 50 feet long sometimes, go figure. But the reason why they had it by the door is obviously so when the guy or the girl, whoever, comes in to replace the tank, they don't have to go all the way through the house with this big heavy tank. The other one, which is common, are these oxygen concentrators. That's the little box right there. These are rented or leased, and they have, what they do essentially is they draw ambient air from the room, and they're able, they kind of mix it, and what they come up with is this low concentration of oxygen that the person gets. You hear a hum or a pump sound going when it's on. There's an on and off switch on there. I believe most of them only can go to about 4 liters per minute, maybe 6 liters per minute at most. It's very, very low flow oxygen, which is all they really need when they're normally at home. My recommendation is twofold. One, ask the family members ask the patient whether they want you to turn off the device. As the thing runs, it costs them money because they have to get this refilled and they're leasing it. If they say leave it on, leave it on. If they say turn it off, turn it off. Also, these people who are on HOMO2 constantly, they have these special soft cannulas. So I know you guys played with the cannulas in the lab. Those are the emergency cannulas we carry on the ambulance. They make these special comfort cannulas. The part that goes into your nose and the part that rests on your lip, upper lip, it's very soft and very comfortable. My recommendation, and it's up to you entirely, my recommendation is take one of your nasal cannulas out of your airway bag, use that en route to the hospital, and leave their comfort cannula at home so when they get home, they'll have it. Those get lost in the hospital and they're really hard to come by. Just my recommendation. Now, when it comes to obese patients, obviously accommodations for this is we see someone who's 4, 5, 6, 7, 800 pounds. When we walk in the door doing our scene size up, we know immediately that we need more people to help us get this person out of their environment into the back of an ambulance. So that's pretty much a slam dunk. But these people are they're very heavy, obviously. And what can happen, unfortunately, is if you lay them flat on a gurney in a supine position, there's so much weight in their chest, they might be unable to breathe effectively. So we try not to lay these people flat if we possibly can. We sit them up in a Fowler position or semi-Fowler position. And this is a person that might need oxygenation or ventilation on the way to the hospital because they're in this unnatural, awkward position. Don't be afraid to put them on a cannula at 2 or 4 liters just to keep them, oxygenation going. Also, because of the size of the patient, they might not fit in your gurney. Most gurneys only will handle up to about 600 pounds, and that's being optimistic. You might have to call for a bariatric ambulance and a bariatric gurney. What you see here in this picture is just that. That's that gurney right there. I think it's about 1,400 pound load capacity. It's essentially solid metal, all the tubing and everything, and it has the ramp you can see. And some of them actually are mechanical. They'll pull the thing up into the ambulance for you. It depends on the circumstances. But if you walk in the door and there's this really big person and you think you need a bariatric ambulance and a bariatric gurney, you would call for that through dispatch, and they would send out the bariatric ambulance plus probably another unit, maybe even a fire truck. So then you'd have plenty of resources at scene to move this person from their bed or their floor, wherever they might be, to get them safely back in the back of this ambulance. Now, a lot of patients who have chronic medical conditions like cancer, something along those lines, they'll have these intravenous catheters. These are central lines, essentially. They go, rather than like a regular IV that you'd get at a hospital or by a paramedic, this central line goes all the way up into their heart, essentially, or in that area of their heart. So the most common one are PICC lines. These are peripherally inserted central catheters, and you can see it goes up usually from the crook of the elbow and the inside of the arm bends. It goes all the way up, and it goes into the right side of the heart, the atria. And this is usually for giving like chemotherapy medications and things like that, because chemotherapy medications are so cytotoxic. They're so bad for cells. They want to dilute that medication as much as possible through a large volume of blood. So what you probably see something like this in this picture. That's a PICC line with the pigtails hanging out. Your only consideration for this, when you see this person has a PICC line or some similar type of catheter system, you know automatically they're being treated over a long period of time, weeks and weeks and weeks, even months, for some type of long-term therapy. So they have cancer, lymphoma, whatever it might be. This person is sick, and they have these obvious types of problems. Now, the locations vary. The most common, again, is the PICC line, but you can also get these Hickman or Hickman catheters. These are in the chest. Usually, if the catheter is placed in the anterior chest, it could be the right or the left side, or in the neck. This is usually for someone who is going through dialysis for kidney failure, and they have not yet had a permanent AV shunt or graft placed for the process, or is being matured at this time. Either way, the biggest problem with these, of course, is these lines go directly into the venous system. If they were to bleed, that's a lot of blood coming out. Infections to the site are a common problem. Per the County of San Diego, the county says that if you as an EMT are transporting a patient with a central line, whether it's a Grosjean or a Hickman or whether it's a PICC line, the ends should be capped. These little plastic caps go over the ends. They just kind of screw on. And the little clip, you can see the little clip in the picture where that's circled right there. There's a little snap clip, and that should be clipped in place and clamped so that there's no chance of any bleeding or infection being caused by the line being open, essentially. The other ones you see here is you see these are inserted under the skin, so that kind of like circle right there in this lady's chest. That's actually another central line, and that's only accessible by a certain special needle at the hospital. But just again, if you see this particular central catheter that's placed under their skin, you automatically know already this person is in long-term treatment for something pretty serious. So it's, again, it's another clue into what might be going on, why this person might be, not responding to you today. So when it comes to renal failure and dialysis, there's different reasons why. We've probably went over the whole thing about different types of renal failure, acute onset versus chronic. And of course, the person needs to get dialyzed at the dialysis center about 3 times a week. If this person has chronic renal failure, the doctors are eventually going to place a permanent dialysis shunt or graft in there. They're going to surgically take a vein and an artery and they're going to graft it together, or they're going to take a piece of something like a Kevlar type of product, and they're going to link an artery and vein together in their non-dominant arm. So if they're right-handed, it's going to be on the left side and vice versa. Wherever it seems to work best, that's where they put it. Usually it's in the forearm or up by the bicep, depending on the circumstances. It takes time, though, for those dialysis shunts to mature. So this is why this person, in the meantime, might have that central line with the Grosjean central line we talked about just a few minutes ago. Now, problems at the dialysis center. People who do not get dialyzed their normal 3 times a week, if they wait more than about 72 hours, if they haven't been dialyzed in 3 or 4 days, their body builds up a lot of toxins and they become hyperkalemic. And hyperkalemia is a really bad condition, can lead to cardiac arrest, drop in blood pressure, altered mental status. So you might get called to a dialysis center for a person who's unresponsive, who has no blood pressure. That's possibly hyperkalemic state. You can ask the nurses there when the last time the patient was dialyzed. If they say it's been greater than 3 days, you'd only have to guess that this is probably the problem. Another problem can be too is what they do is when the person comes in to be dialyzed, they sit them in a chair and they weigh the person. So they get their body weight. And the idea is they want to draw out all of the bad stuff and they want to put back the good stuff. And they want this person to weigh pretty much the same they did when they came in. The problem that we run into, or they run into sometimes, is that they don't get it right. So they don't put back enough fluids that they took out. So this person becomes hypovolemic, so to speak, and their blood pressure drops. That's the other reason why it happens. So the nurse takes their blood pressure and it's 80 by palpation, and they call 911. And really, the solution for this is to give them more fluids, and why they just don't do that, I have no idea. That's something you might want to discuss with them. But I go on these calls pretty frequently, and this is usually the scenario. Again, questions to ask the doctor, the nurse, or even the patient is the last time you were dialyzed, and if there is some kind of an emergency where the patient has chest pain or shortness of breath or low blood pressure, whatever it might be, during their dialysis procedure, you've got to find out how far into the process they've gone. Have they completed dialysis? Have they just started it? The hospital is going to want to know when you transport this patient to the hospital. If they've just started the dialysis and they haven't finished their normal, cleansing, so to speak, then they'll have to do that at the hospital. If they've already done all of their dialysis and everything's completed, and it's purely just a fluid issue, the hospital can address that in a more simple way. Now, taking blood pressures on people who have AV grafts or AV shunts. This picture right here, that's what a mature like a graft or shunt might look like. And that's these, again, there's these two, the artery and the vein somehow grafted together one way or the other. This takes time to get big and thick and mature, and this is where the nurse at the dialysis center puts their needles into those two ropey looking vessels right there. We would never, ever, ever take a blood pressure on anyone who has a shunt or a graft because the pressure can actually damage the device, and it's really hard to repair these things. They actually cannot be repaired once they're damaged. They have to move to the upper arm. So if they do it in the lower arm and that gets damaged, they have to move to the upper arm. It's really troublesome. So we don't ever want to take a blood pressure on that arm. And again, it's usually their non-dominant arm. So again, if they're right-handed, it's probably on their left side. And the other thing is not that it totally relates to this, but patients who have had mastectomies or they've had lymph nodes removed due to cancer from their breast or underneath their armpits along with their mastectomy, they normally will not want you to take their blood pressure on that particular side. So if they had a mastectomy to their left side of their body and they'd had some lymph nodes removed from that side, you should probably not do a blood pressure on that arm. Now, I've heard different things. I've read different things about this. The only time we're really concerned, it's not the mastectomy that's really bothersome here for this. It's the lymph nodes being removed, because if you apply pressure to that arm with a BP cuff, you can actually cause edema, swelling to whatever's left of the lymph nodes there, and it can cause some permanent problems. So more than likely, the patient will tell you, I had a bilateral, or I had a to the right side or left side mastectomy. Please don't take my blood pressure on this arm or either arm. Now, women do get bilateral, I think they call them radical mastectomies. And along with that, usually they take some lymph nodes in the process. So if you cannot take a blood pressure on either arm, you can always take it on their leg. You can take a leg, you can take a lower leg or even an upper leg blood pressure. It's fairly accurate, but it's the best thing to do. What else with this? Okay, that's about it, I guess, with that one. Feeding tubes. So feeding tubes, this is a person who's semi-conscious or unconscious. They're unable to get out of bed, and they're unable to feed themselves due to their level of consciousness or some other reason. They insert these feeding tubes through the abdominal wall into their stomach, and they're fed a liquid diet through, it kind of looks like an IV bag, but it basically drips in food, nutrients, and all that. The biggest problem with these I've seen is, one, they get infections around the incision site, which is probably not the most common thing. But the most common thing I see is they get pulled out inadvertently. As the nurses, because these people are going to be more than likely in either a nursing facility setting or even a home setting with a nurse that comes by and checks on them every few days. But they go to log roll them or move them around or shift them around or clean them or wash them, whatever they do, and the tubing gets pulled out, and it needs to be replaced surgically by a physician. You can't just stick it back in, because it probably won't go back into the stomach where it's supposed to go. It'll probably just go into the perineum, and then now you have all this problem with infections and things like that. So if you inadvertently pull one of these things out, it's not a big deal unless you don't report it. So, fess up and go, gee, we were loading the person on the gurney and my partner and I grabbed the tube by mistake, and it got yanked out. It got displaced a couple of inches out where it should be. Tell somebody, document it, tell the hospital, and they'll reinsert a new one to make sure that it's, obviously a sterile process by a physician. Ostomy bags. So this is a person who has some type of large intestine problem. So what they've done is they've taken out part of their large intestine and they've rerouted the rest of it out through the abdominal wall. You can see the little appliance that they kind of glue onto the skin right there, and onto that clips a bag, and their feces and gas all goes out into this ostomy bag essentially. My recommendation is if they have an ostomy bag, and there actually are internal ones as well, but the most common you see are these external ones, like you see with this picture right here, this young gentleman down below. If they have an ostomy bag in place, they'll definitely tell you, assuming they're conscious, of course. But if it's full of gunk, I would highly recommend have the patient themselves or their caregivers change it before you transport. It's going to sound gross, but I've actually had these things rupture before en route to the hospital. So that's probably the last thing you probably want to happen. Now, we talked about Foley catheters, urinary catheters before. Again, our biggest concern with this is that this thing's attached. You can see down here on the lower left side, the catheter goes up the urethra, and the tubing goes down. There's a large bag that the urine goes into. Remember that tubing is about 6 feet long. It can get tangled and caught, and I don't think this gentleman's going to want you to pull that thing out of his wee-wee. That might be a little painful with this. Other concerns for me is when I see someone with a urinary catheter, I look at the color of the urine that's in there, and it should be fairly normal color that you and I would urinate out, kind of a yellow color or dark or light yellow color. If it's brown, that means there's blood in their urine, and their bladder's bleeding, something like that. And also, I'm not so much worried about the volume because it's not really something we do, but I'd like to just look at the color of it, and I look in the tubing. The clear tubing that extends past the blue tubing there, the 6 foot long tubing, it's clear. And I look in the tubing, and if you see kind of like growth in there, like wispy, it kind of looks like wispy white strands of growth. Then I would definitely consider this catheter to be in the patient way too long, and it's a higher probability this person has some kind of urinary tract infection or even sepsis from that. Probably one of the number one problems with people who have urinary catheters like this, they get bladder infections, which lead to kidney infections, which lead to sepsis. So document what you see, report it to the hospital wherever you're transporting them. The last thing we'll talk about is interventricular shunts. So when babies are born, sometimes some of these babies they're producing too much C-spine fluid, and it causes intracranial pressure buildup into the ventricles. And so what they do is they place one or two of these shunts into the cranial vault, and the excess C-spine fluid leaks down into their abdominal cavity and is absorbed by the body, essentially. Parents are fully aware this is happening, and the reason why they might call you is because the child is acting abnormal, is posturing, seizing, kind of looks like they have a head injury, because basically what's happening is their brain is swelling, or the pressure around the brain is increasing, putting pressure on their central nervous system. So again, the family will be aware of this. It just means one of the shunts or both shunts are blocked. They need to be replaced at the hospital by a surgeon, obviously. So transport the patient to the hospital, treat them symptomatically, and there's nothing you can really do in the field for these other than just keep them going until you get to the children's hospital. I think we're done with the chapter.